And now for our CSAT pearls. Most phyllodes tumors are benign. When phyllodes tumors behave in a malignant fashion, they behave like sarcomas. This means that they do not spread to the lymphatics. They spread locally and via the bloodstream to distant sites. This means that the treatment for a malignant phyllodes tumor of the breast is a mastectomy or wide excision without axillary lymph node dissection. Patients who present with unilateral eczema or a unilateral eczematoid lesion involving the nipple areola complex should have a biopsy done. They should not have a trial of steroids because steroids will improve the clinical appearance of Paget's disease. Pudorage is lymphedema of the breast. It's due to infiltration of the lymphatics from the breast. It is not due to skin infiltration. Inflammatory breast cancer is a clinical phenomenon. It is characterized by the appearance of inflammation in the breast, rubor color, and possibly dullor. It does not mean that there is an inflammatory cell infiltrate. In fact, in inflammatory breast cancer, there is no inflammatory infiltrate on histology. As a general principle, if a cancer is characterized by a rich, prolific inflammatory infiltrate, usually lymphocytic, it has a good prognosis. A rich inflammatory infiltrate implies that the cells are well differentiated and therefore the body is able to recognize antigens on the surface of the cancer cells. If, on the other hand, there is no lymphocytic infiltrate, it means that the cancer is so anaplastic that the body is not able to recognize any antigens on the surface of the cells, and therefore these cancers usually have a bad prognosis. Medullary cancer of the breast, which is characterized by a very prolific lymphocytic infiltrate, has a good prognosis. The benefits of mammographic screening for breast cancer is doubtful between 40 and 50 years old. Hence, the new United States Preventive Services Task Force recommendations that we start breast cancer screening at 50. Abnormalities which make a mammogram suspicious are microcalcifications and speculation, anatomical distortion. Mammograms are classified according to the BI-RADS classification into 1, meaning a perfectly normal mammogram, 2, an unequivocally benign finding, 3, probably benign, but a short interval follow-up investigation is recommended, 4, suspicious and requires biopsy, and 5, highly suspicious and requires biopsy. It is always better to biopsy a suspicious breast lump by using a core needle rather than a fine needle aspiration. Core biopsy allows for histology and allows for the testing of the specimen for estrogen and progesterone receptors and for HER2 overexpression assay, which allows us to start neoadjuvant therapy in patients with advanced disease. Histology is more important in patients with early disease, in patients in whom we are contemplating breast conserving surgery. And the major point in the histology that we are interested in is whether there is in situ disease, and if there is in situ disease in the histology, how extensive it is. The presence of in situ disease occupying more than 25% of the biopsy specimen on the histological slides, a condition which we refer to as extensive intraductal component or extensive intraductal cancer. The presence of extensive intraductal disease in the histology suggests that the cancer is either diffuse or multifocal. The implication of this is that what we are feeling, that small lump that we are feeling, might not represent the full extent of the disease. In patients with a small lump who manifest extensive intraductal component in their biopsy specimen, those patients should have the cancer mapped by a more sensitive modality than mammogram, preferably either breast MRI or breast-specific gamma imaging. Non-palpable mammographic abnormalities are biopsied by first localizing them radiographically with a hook needle under mammographic guidance. In developed countries, a mammotome is preferable to hook needle localization. The mammotome is similar to the core needle biopsy instrument in structure, except that the shaft is hollow and allows for the specimen to be vacuumed into a specimen container, thereby freeing the biopsy channel to allow reaping of another biopsy specimen. Treatment of breast cancer depends on the stage. In general, for stage 1 and 2 disease, treatment is surgery initially, followed by adjuvant treatment. For stages 3 and 4 disease, it is the other way around. Treatment is by neoadjuvant or primary systemic therapy, followed by assessment with respect to the possibility of performing surgery. The staging systems that are currently used are the American Joint Committee on Cancer, or AJCC system, and the TNM system. The Manchester classification is no longer used. Surgical treatment of breast cancer should be divided into two components. The first component is management of the breast, and the second component is management of the axilla. The primary cancer may be managed by breast-conserving surgery if the tumor is less than 5 centimeters in greatest dimension, or at a greater size if the patient has large breasts, and if the histology does not suggest that the tumor is more extensive than it appears. Breast-conserving surgery should not be forced on the patient. The patient should be told the advantages and the disadvantages of breast-conserving surgery versus mastectomy and allowed to make up her own mind. The axilla is managed by sentinel node biopsy if the patient does not have palpable nodes, and if the sentinel node is negative, no further treatment of the axilla is necessary. All other patients require a formal axillary lymph node dissection, in which the aim of treatment is to remove at least 10 lymph nodes from Berg's levels 1 and 2. Surgical specimens are routinely sent for histology, estrogen and progesterone receptor assay, and HER2 overexpression assay. Adjuvant treatments, except for aromatase inhibitors, are usually not started before 1 month has elapsed since surgery. This gives the wound time to heal before starting these modalities which may inhibit wound healing. We need to know the rules for determining who gets adjuvant therapies. All patients who have had breast conserving surgery will need to have radiotherapy. Those patients who have had mastectomy only require radiotherapy if 1, 3 or more nodes are involved by metastatic disease, or 2, cancer cells are visible within 0.5 centimeters of the posterior resection margin. That is the margin which used to be in contact with the pectoralis major fascia. The best way of determining who will benefit from chemotherapy is to plug a number of prognostic indicators into a statistical model available online at adjuvantonline.com. These prognostic indicators include number of axillary metastases, tumor size, tumor grade, age of the patient, and estrogen receptor status. Alternatively, a genetic assay may be done on the resected cancer to determine the likelihood of metastases and therefore the likely benefit from chemotherapy. Premenopausal women with estrogen receptor positive tumors should be treated with tamoxifen for 5 years. Postmenopausal women with estrogen receptor positive tumors should be treated with an aromatase inhibitor for 5 years. Patients with estrogen and or progesterone receptor negative tumors do not benefit from anti-estrogen therapy. All patients between 35 and 55 years old who present with a breast lesion which turns out to be benign on biopsy, all those patients should have their 5-year risk of developing breast cancer calculated. This is done by using a statistical model called the Gale model. At least the Gale model is the most popular of the risk assessment tools. The risk calculation is based on the age of the patient's age at menarche, the patient's age at first live birth of a child, the number of first-degree relatives with breast cancer, the number of previous benign breast biopsies, the presence of atypical hyperplasia in any previous benign breast biopsy, and the patient's race. The Gale score is simply the patient's 5-year probability of developing breast cancer, and if it is 1.7% or higher, the patient qualifies for prophylaxis. Prophylaxis is with raloxifene or tamoxifen. Raloxifene is preferred because of its smoother side effect profile. Raloxifene is administered for 5 years and reduces the individual patient's risk of developing breast cancer by half, by 50%. It does not completely eliminate the risk of developing breast cancer.